Hello friends, today we will discuss leprosy. Leprosy is a chronic granulomatous infection caused by Mycobacterium tuberculosis. Mycobacterium tuberculosis is very slow growing pathogen. So the incubation period is pretty long. Average incubation period is 3 to 5 years. The disease is slowly progressive and results in permanent damage. Leprosy chiefly affects the cooler part of the body like skin, peripheral nerves, respiratory tract and eyes. So we discuss a case report. A 20-year-old man reported a large, single, hypopigmented, well-defined anesthetic lesion on his arm, which had been present for 2 years. So initially, most of the leprosy cases would present in this typical feature. So we must suspect one of the differential diagnoses as leprosy. But this hypopigmented patch can also be caused by a fungal infection, dermatophyte or tinea versicolor, or even a leukoderma can also have a similar clinical presentation. We need to differentiate that. The diagnostic tool for leprosy is smear microscopy, that is gold standard. So slit skin smear is taken and stained with Zn stain would show presence of Mycobacterium leprae, acid fast bacilli. India is one of the countries which has a large burden of leprosy cases. In 2018, number of registered cases were 85,000. And new cases reported in 18 were 1,20,000. India is one of the countries, and the status is leprosy eliminated, and the status was awarded by WHO on 31st December 2005. We must understand the meaning of word elimination. That means the leprosy cases are there, but the prevalence is less than 1 in 10,000 population. Now, clinical manifestations of leprosy chiefly affects skin, nervous system and bones. So skin, the usual presentation is pale anesthetic macule or nodule ranging from 1 to 10 centimeter in size, as we already seen that in clinical case. In a chronic case, there may be a trophic ulcer development. The nerves are affected and it usually shows infiltration and thickening. So there would be anesthesia or paresthesia or sometimes neuritis in a region and in nerve which is being affected. Long standing, the bones will also get affected and there would be a resorption and shortening, especially the digits, and this all thing would lead to a progressive disfigurement. We'll see this clinical feature. You can see over here a hypopigmented patch, that is initial presentation, nodules on ears, nerve enlargement, neurological deficit because of superficial nerve involvement is also evident, and on chronic staining there would be development of a trophic ulcer. Leprosy is a chronic disease, and this would lead to certain complications. These complications are especially deformities. One of the most common deformity seen is lion face or facies leonina, where face looks like a face of a lion because of large nodules development which are symmetrical. There can be a saddle nose, destruction of nasal bridge, or claw hand, and also hand or foot drop. Once again, it's a neurological complication. There is another complication known as Lucio phenomena, which is seen in Mexico and Caribbean island, in which there are multiple ulcerations because of dermal infiltration of Mycobacterium leprae. This ulceration can be infected by a bacteria, leading to secondary bacterial infection, and can be a very serious complication. If you can classify leprosy broadly, it can be classified into two forms. One is lepromatous and other is tuberculoid. Clinical manifestation, if you see, the lepromatous leprosy would present with nodules which are multiple, while tuberculoid leprosy would present with hypopigmented patches. Now we discuss pathogenesis of leprosy. Mycobacterium leprae is discharged in nasal secretions, and long-standing exposure is a risk for development of leprosy. But the main risk factor is the immune system. If immune system is competent, the individual is naturally resistant to leprosy, and there would be asymptomatic clearance. While if there is a deficiency in immune system, there is a chance of development of symptomatic leprosy. As we can see, the immune system, there are two components: cell-mediated immune response and humoral immune response. In case of a symptomatic leprosy, if cell-mediated response is good, then the patient would develop a tuberculoid leprosy, in which there would be a formation of a granuloma, and this response will be able to control the growth of Mycobacterium leprae, and only few organisms are seen. So this pole of the disease is called as tuberculoid pole. Now in case Th2 or humoral response is the principal, then humoral response is not competent to clear Mycobacterium leprae. So there will be a progression of the disease, and Mycobacterium leprae will not be contained, but it will continue to replicate, and this form of the disease is called as lepromatous fold. So you can see over here, broadly we can classify leprosy into either tuberculoid or lepromatous. But it is a spectrum, and we can see over here that in between there is a borderline leprosy. So what happens? You can see over here in tuberculoid pole, there is a containment of the bacilli, and number of bacilli is much less. While in case of lepromatous, the humoral response is not able to contain the bacilli, and bacilli would proliferate, and macrophage are seen which are dying, and these are forming macrophages. So we can see Mycobacterium leprae would continue to grow within the cells, especially neuronal cells. This growth will lead to release of inflammatory mediators and T cell mediated cytolysis. So damage to nerve can occur via different mechanisms. First of all, edema leading to ischemia and death, or apoptosis or demyelination. These all mechanisms play a very important role in damage and destruction of nerve cells. Classification of leprosy. So initially patient would be in a stage of indeterminate leprosy, and if immune response is chiefly cell mediated immune response, then patient would develop a tuberculoid leprosy, that is paucibacillary, either tuberculoid or borderline tuberculoid. If immune response is chiefly humoral immune response, then it would be multibacillary, and the forms may be lepromatous leprosy, borderline lepromatous, or borderline leprosy. Now, during the course of the disease, the patient may experience certain reactions which are called as lepra reactions, and lepra reactions are classified into two types, type 1 and type 2. Type 1 reaction is mediated by Th1 cell or cell mediated immune response. Type 2 is mediated by Th2, that is humoral immune response. Type 1 is basically type 4 hypersensitivity, that is relate type, while type 2 is caused by type 2 hypersensitivity, that is antigen antibody complex mediated hypersensitivity. Type 1 is seen in borderline cases, borderline tuberculoid, borderline and borderline lepromatous, while type 2 is seen in lepromatous leprosy, that is borderline lepromatous and lepromatous leprosy. The type of reactions observed in type 1 is reversal reaction and downgrading reaction. Reversal reaction is associated with therapy, while downgrading is not associated with therapy. While in type 2, the reaction are erythema, nodosum, leprosum, and Lucio phenomenon. Clinical presentation in type 1, that would be a edema in a lesion which are already present, and there will be a nerve involvement and damage. While in type 2, there are nodules development and development of necrotic areas. Histopathologically, type 1 shows a tuberculoid granuloma, while type 2 shows neutrophilic infiltration. So, reversal reaction, over here you can see Lepromatous leprosy, there is an enhancement of cell-mediated immune response from humoral immune response, and over here it is reversed from lepromatous to tuberculoid form. But this reversal may be acute and it can lead to a nerve damage that needs to be managed. While erythema nodosum leprosum that happens in type 2, there is an neutrophilic infiltration, antigen antibody complex mediated response, which further aggravates the lesion and clinical condition. If you see the difference between reversal and downgrading, now that both happens in type 1. So basically a response mediated by cell mediated immunity. In a reversal, the patient is reversing from lepromatous leprosy to tuberculoid leprosy, while downgrading, there is a degradation of a cell-mediated immune response, and from tuberculoid leprosy, patient is worsening towards lepromatous leprosy. Reversal reaction is typically associated with the therapy. Cell-mediated immune response plays important role in pathogenesis of leprosy. So there are certain tests by which we can detect or determine the status of CMI, like lepromin test, in which lepromin A antigen is intradermally injected into forearm and reading is taken at 48 hours and 21 days. The reaction which is seen first is Fernandez reaction at 48 hours, which is observation of induration surrounded by erythema of more than 10 mm size. This is a type of delayed hypersensitivity reaction analogous to tuberculin test. This is again soluble lepra antigen and it indicates past exposure to lepra bacilli. Next is Mitsuda reaction, which is observed at 21 days, where there is a development of a granuloma. So granulomatous swelling of more than 5 mm is seen, and this is a cell-mediated immune response against bacillary component of lepra antigen. Now, this test indicates the CMI status, which can be helpful in classification of a leprosy into lepromatous or tuberculoid form, and it can also be helpful in prognosis. So if CMI is competent, the prognosis is good. So now let us just have a brief differentiating point between lepromatous and tuberculoid leprosy. Bacillary load, lepromatous leprosy is multibacillary and tuberculoid leprosy is paucibacillary. Bacteriological index is 4 to 6 grade in lepromatous, while in tuberculoid it is 0 to 1 grade. If you see the skin lesions, clinical manifestations, there are many and symmetrical lesions, and especially of nodular type, which are hypopigmented. In Leprosy leprosy, while in tuberculoid they are very few and asymmetrical and usually of macule type. Nerve lesions, they occur late and usually manifested by hypoesthesia in Leprosy, while in tuberculoid the nerve lesions develop early and there is an anesthesia, and typical sign, thickened nerves are observed. Immunity, in leprosy, CMI is low while humoral immune response is exaggerated, while in tuberculoid leprosy CMI is normal and HI is normal. Lepromine test is negative in leprosy, while in tuberculoid leprosy it is positive. Chief phagocytic cell observed in leprosy is macrophage, while in tuberculoid leprosy it is epithelioid cell. Giant cells are absent in leprosy, while they are present in tuberculoid leprosy. Finally, we will discuss the laboratory diagnosis. Laboratory diagnostic tools are smear microscopy, cultivation in mouse, and antibody detection. So, in microscopy, the specimens are collected from various parts of the body affected by leprosy. The total number of the specimen to be collected is 6. The 4 are from the skin, 1 from earlobe, and 1 from nasal mucosa. Now, 4 specimens from skin are to be taken from forehead, cheek, chin, and buttock. The specimen collection technique is slit skin smear. In this, a cut is put on a skin, and then with the help of scalpel, the edge of the cut is scraped and is taken on the slide. Now the smear, which is prepared from this slit skin specimen, is stained with Zn stain. We use 5% sulfuric acid as a decolorizing agent, and is observed in microscope, and presence of bacilli is noted and grading is done accordingly. Along with that, there are 2 indexes which are to be noted. One is bacillary index and other is morphological index. You can see the smear stained by Zn stain, and large number of Mycobacterium leprae is observed, and depending upon the number of bacilli in the field, it is graded. So 1 to 10 bacilli per 100 field plus 1, 1 to 10 bacilli per 10 field is plus 2, 1 to 10 bacilli per 1 field is plus 3, 10 to 100 bacilli in 1 field is plus 4, 100 to 1000 bacilli per field is plus 5, and more than 1000 bacilli per field is plus 6. So morphological index and bacteriological index. In bacteriological index, total number of bacilli are counted, while in morphological index, the bacilli are stained either solid or fragmented. So in case of a therapy, the bacilli would look fragmented and not uniformly stained, while some bacilli are uniformly stained. So morphological index and bacteriological index is very important to determine the severity of the disease and also to determine the effectiveness of the drugs. Next is cultivation. Mycobacterium leprae cannot be cultivated on artificial media, but it can be cultivated on mouse foot pad and 9-banded armadillo. Now, what are the advantages? Cultivation is very sensitive and it can also be used to determine the drug resistance. The disadvantage is that it is pretty time consuming and it takes 6 to 9 months. And there are several ethical issues with regards to animals. Next is antibody detection. The tests which are used: FLA-ABS, that is fluorescent leprosy antibody absorption test, which detects presence of specific antibody against Mycobacterium leprae. Sensitivity is 92% and specificity is 100%. Another test is ELISA, in which IgM antibodies against phenolic glycolipid 1 antigen is detected. The sensitivity of the test in Lepromatosis is 95%, while in tuberculoid it is 65%. So with that, we come to end of the leprosy, and you can just have a look at this figure and find out the relation of this image with leprosy. Thank you.